are listening to the AOTA podcast. Here is your host, Matt Brandenburg.
All right, today we are joined by two very special guests, Jen Johnson and Amanda Fauner. Thank you both for taking the time to share your knowledge and expertise with us today.
Thanks for having us.
Yeah, thanks, Matt.
Of course, it's my pleasure. Today is a fun episode. I'm really looking forward to it. You have worked together for, was it 10 years you said earlier, Amanda?
Yeah.
10 years.
10 years.
Jen as a certified occupational therapy assistant, Amanda as a licensed occupational therapist. And today we're talking all about OT and OTA collaboration. Why do you both feel it's important for OT professionals to understand the intraprofessional collaboration between OTs and OTAs?
I think it is so important for OTs and OTAs to collaborate together because we are a team and we have to rely on each other. Despite how many years of experience we have, we can still learn from each other. And our overall goal is to be there for the patient and help them succeed, or the client. I feel like it's so important that we're on the same page, that we're open to each other's opinions, we value each other's roles.
Well, to build off of that, Jen, no, I completely agree. And I think what's interesting for me where, like, when I initially went to OT school, I didn't realize that like occupational therapy assistants was a thing at the time. And then when I was in school, there was actually one of my classmates was an OTA that was going back to kind of become an OTR. That kind of like first gave me like a glimmer of kind of like understanding the kind of dynamic and the interplay between both of the professions there. And then when I was out on one of my level twos, I had just a wonderful mentor at the time, though. And she's like, so I want you to know that, you know, this individual you're going to meet, so they're an OTA. They've been here as long or longer than I have. And honestly, the way we practice, you cannot tell the difference who's what, you know, and literally the distinction is within kind of the evaluation process. And she's like, and I think that's really the goal is right where it's, you can't tell kind of who's the OT, who's the OTA, in a really collaborative setting, and kind of how those two kind of work together as well. So I think that's been really cool kind of in my professional side of things to really get to learn about the OTA role more, get to kind of help kind of teach and lead and like take several like level 1 and level 2 OTA students, and kind of get them to kind of become, and I feel like sometimes there's always that initial of like, oh, you're an OT and I'm going to be an OTA. I was like, but really like we can practice the same. There doesn't have to be that distinction. Like there's not really a distinction between how we practice and what our interventions look like. So outside of like the evaluation, but really having quality evidence-based practice, like there's nothing that says we have to practice at different standards or anything like that. And I think that's really the important thing too, where I feel I like the OT and OTA relationship is because it's always been like a really awesome collaborative experience where it's just like another kind of having another OT practitioner that you're able to bounce ideas off of and discuss things and really kind of work together to not only for the betterment of kind of us and our personal and professional growth, but also for our patients and them really kind of overcoming their goals.
Right. And, you know, to kind of bounce off what you said, Amanda, that my field work 1 and 2 were completely different. You know, my first field work setting, there was no quotas. It was just OTs. So it was very different because, you know, I'm learning from her, but I'm also seeing that evaluation process. But she didn't treat me any different. She told me these are the things that you can do, and these are the things that I have to do. And then my second one, I was at Paraquad, and that is just a completely different setting. And then you're also working with PTs and PTAs. I didn't have that same experience. It was just very different.
That's interesting. I think that's true for a large portion of the profession where a lot of practitioners have had the opportunity to work in settings where there's OTAs, OTRs collaborating and it's supportive and, you know, a wonderful way to provide OT services, but a lot of practitioners haven't had the chance to collaborate or, have a field work with an OTA and OTR mentorship. What do you think OTs and OTAs should understand about each other's education and credentials and background as they approach a collaborative setting?
Yeah, I think first of all, it's looking at like OTs and OTAs. It's like we're both earning college degrees. They're rigorous courses. We're having to follow ACOT standards to kind of like achieve that in our programs. We're earning state licensure. We're taking our, kind of boards and passing those to where a lot of kind of like the knowledge base there's a lot of similarities. I think also, and kind of getting to the end of the level 2s. So like OTAs have to complete 2 8-week level 2s, and then OTRs have to complete 2 12-week level 2s. But it's still the same expectations of where you're getting to entry level practice by the end of those. And so I think that's important to kind of know of how rigorous like the programs are. And it's not like one route's necessarily just incredibly easier than the other. And I think that's somewhat of a misconception, is like they're still having to be able to kind of read information, put together interventions, be skilled in their interventions, and work at that entry level practice by the time they complete those programs. So
I really like that answer, Amanda, and it really stuck out to me, Jen, how you were mentioning how we're a team. OTRs, OTAs, we're all practicing occupational therapy, and we're both lifelong learners. What roles would you say that experience and competence play into OTR, OTA supervision and collaboration?
In the setting that I'm in, I have a very seasoned OT who has been in that setting for a very long time. And then I have another one who is a new grad who's, she's been out in the field for maybe a year and a half now. And I could say each one of them provides the same guidance. One may know more because she's a new grad and she has all these fresh ideas. And then you have one who's seasoned and she says, this is what I've dealt with for a long time. This is how I deal with things. This is how I approach. It's just all very different. So I don't feel like there's a distinguish between the two. I feel like I can learn from a new grad versus a seasoned therapist.
And I think it kind of on the other side too, where it's like I've worked in where at times like I've worked on acute care. And so we've had like a variety with Jen, who has 10 years of experience now, very well versed in acute care and really has like a passion specifically for like our orthopedic populations. And then also like on the other side of it, working with like a newer grad OTA too. And again, I think it's, just kind of experience, but also that kind of new knowledge. And there's something that you can kind of gain from both parties there as you're kind of like working together to best support these patients.
I love that. I think it's helpful to our listeners to kind of define some of these guidelines and best practices for collaborating on a professional team comprised of OTRs and OTAs. And I think in order to do that effectively, it's really up to the practitioner to understand roles and understand backgrounds and understand, the experiences that someone has, so we can learn together and provide care at the top of our licenses. What are some of the common collaboration and supervision guidelines outlined for OTRs and OTAs?
The main kind of like understanding or distinction there is with like the OTRs. So we were able to do the initial evaluation. We're establishing that plan of care, I guess, in charge of more of that formal discharge and what that is, and kind of any updates or changes to that plan of care. So if we want to update or upgrade goals for the individual, if we want to kind of increase or decrease like the frequency that we're seeing them, that would more fall under like the OT's scope particularly. But I think there's a lot of opportunities for that collaboration kind of in those roles too. On like the other side, OTAs are going to be able to kind of intervene. And I think in our setting too, we've always had a lot of really nice collaboration where if, like Jen's coming around behind us and saying like, hey, there's kind of been this change in status. I think this is worth either us maybe, looking at the goals again, maybe we adjust the frequency, maybe we adjust the discharge, and we're able to like communicate and kind of collaborate on that. And we're at the point too where it's, Jen's amazing. We trust her judgment, and she has such a heart for all our patients too, where we're like, okay, I see what you're saying there, and able to then like on the OT side of things, we can kind of follow through with those pieces. And I think Jen has like a really good example of something just recently where she had to, kind of lean on those pieces too, but was really able to collaborate lovely, but still stay within like the supervision guidelines.
I love that. Can we hear that example, Jen?
So we had a patient just last week who I went in to see them. They had been evaluated earlier in the week. It had been several days because of very high census at the moment. And when I went in, I had saw something completely different than what the OT saw at eval. There was a change. He was doing much better. He was able to tell me, where he was at, everything that was going on. Even his level of assistance had changed. So that OT wasn't there that day who evaluated him. So I had to go to someone else. I explained the situation. We looked at the chart. I, shared with her the progress that I thought that he was making. And I said, I really think that we should change the frequency to 5 to 7 times a week versus 3 to 5 because of the progress that he's making. And she agreed, and we moved on, and we worked together for the patient. And I like that, they rely on me to come to them. If I don't, then that patient's just stuck in, their regular frequency that they were originally given when the OT evaluated them.
Yeah. And I think this was just like a cool example too of where the individual I wasn't the OT that did the evaluation, where the patient wasn't very alert. They weren't really oriented. They weren't following commands. They weren't really kind of much engaged or in concerns at that point of really concerns of not being able to really participate in therapy much at that point, which I think kind of reflected like the kind of lower plan of care and kind of frequency for that acute care setting. And so Jen coming in a couple days later and be like, oh man, this is a whole different person now. They're doing so much better. They're progressing so much better. I really think we have an opportunity here to make a bigger kind of change and improvement in them by adjusting the status. But again, it took her kind of having that insight and being willing to kind of step out and say, hey, here's what I'm seeing. What do you guys think? Is this something we can do to better meet the needs of this patient?
Right. And I also think that goes back to the trust, between the OT and the OTA. They feel confident in my skills, in my opinion, and what I'm seeing. And then I value them when they think, well, okay, at this point, they're not there, but I totally see where you're coming from, and they're making progress. Let's see what happens.
Yeah, I love that. I think that's such a wonderful example. How would you recommend practitioners begin to establish and develop that trust when they're in settings where they're practicing collaboratively between OTRs and OTAs?
Well, I think one of the first things you need to do is you can't just sit back. You have to talk to each other. And you have to build that relationship. And it's not just a working relationship. This is someone who I work with. I work with all these OTs daily. We rely on each other. We go to each other if we have questions. If I'm stuck or I'm like, I don't have a clue. Like, I feel like that's totally over my head. I don't know what to do. I go to them. And I say, I don't know what to do. Can you help guide me? What's some good treatments that would be perfect for this patient? You're the one that evaluated them. Can you help guide me? But that all goes back to that relationship that you build with the OT and realizing, yes, I can go to them. They're open. They want me to come to them. We're all there to help the patient succeed. And they want to see me succeed as much as I want to see them succeed.
Absolutely. Amanda, was there anything you wanted to add there about, establishing that environment of trust? I think Jen laid out some really important principles to function and establish within an environment like that.
Yeah, absolutely. I think also kind of coming in just with that mutual respect for each professional and coming in. And I think there's also a lot of opportunity from like the OTR side of things too, to make sure that we're coming in as team members and collaborators with like the OTAs, not coming in as like, well, I'm the OTR and I get to make the final decision on things. It's really working together as a team and having that mutual respect. And I think like the OTs, I feel like we have a little bit more of an opportunity to kind of really help set that, kind of set the tone for that relationship and what that's going to look like. And really like valuing kind of each other for their differences and also their strengths too.
Right. I completely agree with that.
Yeah, I love that. Already we've got some great, guidelines and recommendations for our listeners. I'd love to run through kind of each step of the OT process and give our listeners kind of some quick guidelines about the roles and responsibilities of OTRs and OTAs during each step of the OT process, and maybe even some recommendations on what they could try and improve or what they should be striving for to have a collaborative environment that leads to best possible outcomes for patients. So what are the roles and responsibilities of OTRs and OTAs, starting with the evaluation process?
Yeah, so for the evaluation process, normally that's going to be more the OTR kind of overseeing that. And we kind of do that initial evaluation with the patient. So kind of forming that initial occupational profile, doing a list of kind of our assessments to really kind of evaluate and assess not only kind of like their deficits, but also functional limitations, and really figuring out like what their goal is for that rehab process. What are they wanting to work on and what's that important thing for them? And so then as a result of that, we're kind of constructing our kind of generalized assessment of what we saw as like the deficits, areas for progress, and then also kind of creating those goals that are really going to drive those interventions as we kind of move forward in that therapy process there. And then also like the OT kind of for that evaluations, we're going to create that plan of care. And so in like an acute care setting, that would be something like, okay, we're going to see them a certain number of times a week while they're still here in the hospital. An outpatient where I primarily work now, that's going to look like, okay, how many times a week and for how many weeks are we going to see them based on their kind of diagnosis and also their kind of functional limitations and their current status and what seems kind of appropriate for that.
I love that. So from the OTR side, a lot of this emphasis is on assessing for goals, establishing goals, determining frequency and duration of care, and also doing so in a way to where, like Jen shared previously, that can be changed and updated based on someone's performance and response to intervention. What about from the OTA side, Jen? What's kind of your take on the evaluation process and how collaboration can be encouraged in that step of care?
In the acute care setting, it's a lot different than the outpatient setting. If I was working in outpatient with Amanda, she could, say, okay, I need you to do these assessments, and she'll delegate those tasks to me. On the acute side, it's a little different, because initially the OT is going in and she's doing the evaluation. But while she's doing the evaluation, she may step out and ask me, maybe they weren't able to get the patient out of bed, but this is what they're seeing. Do you feel comfortable going in and going from there? It's a lot different, though, outpatient versus, acute care.
Yeah, and there's going to be, differences by setting, by location. That's one of the difficult but also beautiful things about occupational therapy practice is there's so many different environments where OT services can be beneficial, and where collaboration between OTAs and OTRs can really elevate the quality of care that's being provided. How about that next step in the OT process now, where we're getting to intervention? What are the roles and responsibilities between OTR and OTA practitioners during intervention?
So on the intervention side of things, this is where it's can really be opened up, where either the OT or the OTA is able to kind of provide those interventions under that initially established plan of care. So we're able to plan kind of the treatments and what that's going to look like, what kind of areas or goals we're going to assess for each session, and kind of be able to get really creative too of meeting the patient where they're at and really staying client-centered in that.
And I feel like, the OTA during this process, she needs to be able to understand and support the therapy goals that the OT set in place so that she can follow, that we can follow through with those and make strides towards those goals for the patients.
Absolutely. So intervention happens. We've already established this positive, collaborative environment where there's feedback, there's communication, regular, updates, whether it be during stand-up meetings or emails, or maybe you're catching each other in the hallway. How are the roles and responsibilities of OTRs and OTAs during the process of targeting and evaluating outcomes and updating the plan of care?
Right. So we kind of touched on that earlier, as well as, with the patient that I had last week, and I go in and I'm like, okay, we definitely need to improve increase the frequency. But there are times where I may go in and I'm like, okay, we're not seeing improvements, or there may have been a decline in status. We need to lower the frequency. Maybe it's not appropriate for us to be going in 3 to 5 times a week. Maybe we just need to check base 1 to 2 times a week. It also goes into if we've met some of the goals. In acute care, I don't see patients every day, the same patients every day. Sometimes it's completely different unless it's an orthopedic patient and I'm seeing them every day. There may be a time lapse between the time they were evaluated and the time that I'm coming in to see them in a treatment. So in that time, there could be a lot of improvement. There can also be a lot of decline. So I need to be able to collaborate with the OT and say, okay, maybe the frequency needs to change, or maybe the goals are not appropriate. Maybe they're a little more high functioning than what they were on eval.
And I think to kind of build off of that too, I think it is really setting specific of kind of what that process is going to look like. In acute care, it's going to be, usually they're not there for a strong duration. So usually the OTAs might come in and kind of do the majority of those treatments in that setting. And again, reaching out if there's a change or concern that we need to kind of make there. And then to speak more from an outpatient standpoint with that too, it's typically about every 10th visit following Medicare guidelines, we need to have a reassessment where we're reassessing those goals and kind of the areas that we've been targeting in our interventions for the past several visits. And so in that kind of process, or creating a progress note, can kind of happen in a couple different ways. Typically, we'll have that back on the OTR to kind of do that progress note and that evaluate, or that kind of reassessment, where we're kind of checking in and then able to make additional kind of recommendations, or to say, are we going to extend that plan of care? Are we going to change that? Are we going to discharge because they're getting close to that? But also there's an opportunity for OTAs to kind of participate in that as well. And that if they've kind of shown that they're competent in certain kind of assessments, being able to kind of do those assessments as part of their intervention time with them, and then kind of sending that over to the OTR, or having that discussion with the OTR about those plan of care changes or maybe frequency changes. They're able to kind of build on that and kind of work together to really kind of make those decisions on looking at kind of where they're at and targeting their overall outcomes and reaching those goals.
Absolutely. Thank you for kind of painting a picture of that process, Amanda. And it's just so clear to me how important it is to collaborate between OTR and OTAs, and how much of a benefit that can be, not just to the patient who's going to receive a higher level of care, but also to the practitioners. It boosts your confidence and boosts your competence to be on a team, and not just feel like you're in a silo doing things alone. I wanted to mention some AOTA resources related to OT and OTA collaboration. I'm going to link many of those resources in our episode description for our listeners to check out. But one is an ethics advisory opinion that states OTAs receive clinical supervision from OTs, and OTAs can provide administrative supervision to OTs. That kind of stuck out to me when I was reading, and I wanted to ask both of you your thoughts on it. Can you kind of describe the clinical and administrative supervision and share how OTAs and OTRs can provide both effectively?
Yeah, so I think kind of some distinctions there from the clinical and administrative supervision. So with typically kind of in a traditional rehab setting is like the OTRs would be supervisory over like the OTAs in terms of the evaluation, the plan of care, kind of following through with those components there. So where the OTA can kind of come forward and say, hey, I'm thinking about this. Usually it's going to be the OTR that's going to make that final decision and make those kind of changes in the documentation to reflect it. But I think it's kind of interesting where we can also have this dynamic where an OTA may be a leader. And so they may be in like an actual as a supervisor or as a manager or head of like rehab in some departments. So I know that tends to be seen a lot in the kind of skilled nursing facilities around here where you may have a PTA or an OTA that's the director of rehab there. And so while they're clinically not necessarily the supervisor role in terms of patient care management, they can be an administrative supervisor and leader kind of over the OTs in certain settings. So
I love that. Thank you for clarifying that distinction for us. What recommendations would you give to practitioners who are working in settings with other OTs and OTAs, whether it be in a clinical supervision or administrative supervision role? What would you recommend to them to maximize their practice?
Well, I really think that you had that level, it goes back to that level of respect, and you have to understand their roles, whether an OTA is, now she's in the position of being the director of rehab. You still have to have a working relationship, value each other's roles, understand, yes, she is an OTA, but she's also the director of rehab. So she has that level of experience because obviously she has chose that and someone has, chosen her to be in that position. Her level of experience plays into that as well.
Absolutely. How about you, Amanda? Are there any additional recommendations you'd like to add?
Like it always comes back to kind of like getting to know the individuals in your team there and being willing to kind of, I guess, ask questions and get to know each other and kind of understand their interests in kind of specialty areas or where they focus on. And but I think also kind of being vulnerable at times to say, hey, I don't know everything. And that's okay. If we can kind of come together and say like, oh man, I'm thinking about this, or I saw this with this patient. What do you guys think? I think there's just a nice opportunity for kind of collaboration and being able to, again, do the best by your patients if you're, able to kind of run things off each other and, like you said, not work in a silo. And I think I was in my first few years of outpatient where I was like the lone OT there too. And it was overwhelming and kind of daunting where it was like, then I would come to acute care and it'd be like, oh, we had this like awesome collaborative team where it was just like, oh man, it's just so nice to have like somebody to bounce off ideas off of, and to kind of like discuss things and to feel like, hey, here's what I'm thinking. Does this seem like I'm heading in the right direction? Do you have anything to add? And so I think for me too, and now kind of being an outpatient where now we've grown and there's like 4 OTs down there with us. It's really beautiful to have that opportunity for collaboration and to kind of have to bounce ideas off each other too. And I think, and again, I saw this at like this continuing ed I went to like a couple years ago, and that might make sense for this patient, and vice versa. I also think that speaks to the nice thing about like having students in the clinic as well, is because it's like oftentimes they're hearing the more recent research and evidence-based practice. And while we come with a wealth of experience and knowledge too, when you're in clinical practice, it's really hard to necessarily always get into the research and have really accessible research to kind of guide your practice there too. So being able to, even have the students kind of bring forward information to work together to, again, be as collaborative as possible in whatever setting you're working.
And I think it's also important, talking about the student being part of that, they get to see how the OT and the OTA work together and how that relationship works. In my first fieldwork setting, I didn't get to see that because there wasn't any OTAs. It was just OTs working together. So I didn't see the relationship that could be built between OT and OTA. And now that I'm in this setting and we have, multiple OTs and just very few OTAs, but you see the relationship that we've all built together and how much we really do rely on each other to bounce off those ideas. And I think that makes us a really strong team when we are able to work together. We're valuing each other's opinions and we respect them enough to go to them and say, hey, I'm stuck. I need help progressing this patient. Do you have any ideas? What could I do differently to help build on that? I think it's important. Amanda and I both always have taken students, and I just think it's great that they can see that relationship that she and I have, as well as myself and the other OTs at the hospital.
Yeah, you're both wonderful examples of that, and applying, those principles of mutual respect, of vulnerability, to enhance collaboration in practice. How have you seen doing that impact your own clinical reasoning and professional practice?
Well, put it in this case, Amanda is absolutely amazing. I take courses, but Amanda, when she does her continuing ed, she goes for it. She goes, and I strive for that, but I just don't know how she does it with kids at home. I have kids at home too, but she is amazing at, taking that extra step. And part of me, when I'm like, I want to be like that. I need to get to that point.
That's amazing. And how about for you, Amanda?
A couple examples I can give, but so when working like acute care with Jen, and so I keep her as kind of like our go-to for that orthopedic follow-up care. So she's always going in there for our orthopedic patients and kind of for that next day treatment. And a lot of times when OTs were going in for the eval, it's kind of like a quick and dirty, like, what do we think they need? Usually they're in a lot of pain. They just had surgery. We're trying to get them up, but there's only so much we can really do that initial day. And so really relying on kind of in our setting, specifically Jen, to be able to kind of follow up with those pieces too. And she is like the adaptive equipment queen. So she is fantastic at like educating patients on all of that too. And so a lot of times if I have any sort of students with me, whether it's an OT or OTA, I always want them to spend time with Jen just to see that of like, hey, here's something that she absolutely excels at. Here is just like a beautiful example of what that looks like, the benefits of like OT, and kind of in this more specific nuance kind of thing that you don't always, while it's a part of our practice, you don't always get to see it to the full extent that like she's able to kind of do with her patients on a regular basis. And so I think it's, again, kind of leaning into each other of like what their interests are and what they kind of specialize in, and being able to really just kind of know your team and know who has strengths in certain areas. And like I said, Jen's our kind of our go-to when it comes to those follow-up orthopedic care, and especially adaptive equipment and going over like the hip kits and all of that with individuals. And she really thinks about like that full picture of like if they are going home and they're needing to shower, but they have this precaution, and walking them through all the bits and pieces of that to a point where I think a lot of us wouldn't initially think to go into like that level of depth, especially in like an acute care setting. But it's really a wonderful thing and such a great service that we have Jen being able to do that for our patients. But I think, again, it just comes back to knowing your team and kind of what their specialties is. And I have a OTR that I work with down an outpatient that she spent like 20 plus years working in skilled nursing facilities and has done a wild amount of wheelchair evals in her career. And so I really want to learn and be better at wheelchair evals. But like when we have these really complex evals come across, like I just know that I was like, all right, this needs to be on Heather, because she's going to do it the best, and she's the best one kind of for the job there too. So again, I think just knowing your team, knowing where the strengths are, also knowing where those interests are too, and then kind of finding out your own little niche really makes for like a nice opportunity for good collaboration. And again, I think that kind of distinction of like OTA versus like OTR kind of falls away, where we're just all OT practitioners and able to use our team to the best of our abilities.
And I agree. And especially, when, there's a process we have every morning when we go through and we're assigning patients. And you kind of have to look at that, and you're looking at each other's strengths and kind of saying, who would best be fit to go into this situation, and what skills can they bring to the table to, help that patient.
That's such a valuable approach to care, beneficial for the whole team, for the patients, for everyone involved. Can you share an additional case study or some more personal examples of how you've seen OTA and OTR collaboration lead to positive outcomes?
Well, I think another one would be kind of with splints. That's not my strong suit. We now have an OT on board who came from a background of splinting, and, her initially going in and building the splint for the patient, and then me going in following her and, noticing, okay, well, this may be a problem. The patient's not wearing it like they should, but then her going back in after me and reevaluating the situation and saying, okay, this is what we could do different, or this is how maybe you could lead the next treatment session, and help encourage the patient to wear that splint.
Yeah, no, I think so, where it's like she's going in to kind of fabricate like the custom orthosis there in acute care, and then you're able to go in kind of for that second or that next visit to kind of do the splint check, follow up with things too. And again, feeling comfortable to say like, hey, this is something that, for years we weren't really able to offer that service at our hospital. And now kind of with her kind of coming on board, and I know like we would randomly like run up, but that was always based on if our schedule allowed us to kind of thing. But now to kind of have that consistency too. And then you being able to kind of lean on her to learn to say, hey, I'm not familiar with this, but I'm willing to learn, and I want to know and do right by everybody involved.
And the thing, you have to be comfortable. If we didn't have that relationship with each other and that trust, I don't know if I would be comfortable going to her and saying, I don't feel comfortable doing this, or I'm not sure what I'm doing wrong. Mm-hmm. So it goes back to that collaboration and that trust and that relationship that you have built together to know that we can rely on each other.
Yeah. And I think that's something that kind of comes with kind of just growth and practice too, of being okay to say like, hey, I really don't know, but I want to do the best I can. And I think that was always like a guiding principle for me, and being an outpatient there was like, I have never seen this before, but I know I can do something about it, because let's be real, nobody's going to travel an extra like 30, 40 minutes to like get to maybe a more specialized clinician. So what can I do to kind of equip myself and equip my team where we're able to provide the best care we can for this individual here, where they're able to get services.
Right. And then that goes along with the professional development, and how amazing you are at you reaching out and you're looking for those opportunities to help build yourself so that you can provide those services for your patients, which is amazing.
Yeah, these are wonderful examples. I am feeling like I want to work on the same team as both of you, because I can tell this collaboration is just how it should be. And I like how you're giving us examples of how collaboration can happen in, a treatment session right there together. It can happen, between sessions. It can happen, electronically, but there's so many opportunities to collaborate and to include each other as a team. And I think it's really important for all OT practitioners to maximize those opportunities and take advantage of them.
Right. Whether it's you're modeling something for each other and saying, well, this is how I would position them, or this is how I would transfer the patient. We're doing these things in the office on our lunch break, or, while we're documenting. We're relying on each other. Oh, hey, can you help me here with this?
Or calling the other on the way home to say, hey, here's what I saw and here's what you're going to see tomorrow. And I'm sorry I won't be there, but here's what I'm thinking, but see what you think. Yeah.
Exactly. And we do that so often, texting or secure chats or, just in person, quick in the hallway. Hey, this happened today. We need to talk about this later, but it all goes back that we just have an amazing team as well.
I love it. And I want to ask about how students can begin to prepare to be a part of a team like this, or, contribute to establishing a team environment like the one you practice in. How would you say OTR, OTA collaboration could be integrated into academic curriculums to benefit, university students and practitioners alike?
Yeah, I think that there's a lot of opportunity just for whether it's collaborative days or collaborative experiences. Because again, I say even going through my OT program where I didn't quite have that full understanding of the OTA role until I was really out in practice and kind of seeing it firsthand for myself. So I think there's definitely some opportunities that can have collaborative days, or, maybe projects or joint things. I know some schools are kind of really working with the different OTA schools in the area to kind of help support that. I always try, if I have an OT or an OTA student, I always want them to see both sides of the coin. So I want them to see an OTA in action. I want them to see an OTR in action. And I want them to see that relationship and kind of how it builds. And sometimes I will have them go specifically to with Jen to say hey, she's an OTA. I want you to kind of observe this and watch how well she does, and watch her and how she collaborates with her teammates as well. And kind of touches back bases for that too. And also, when does she say, hey, this is outside of my comfort zone, and when does she reach out and ask for help? Also, I'll try to send kind of students just so they can kind of see those dynamics in a lot of our different settings as well, because I think there's a lot of value in seeing that firsthand. I think talking about it's one thing, but then being able to really observe it and what that relationship looks like, I think can be really, really helpful and really beneficial.
Right. And then, as we also send our students with the PTs and the PTAs and the speech therapists, observing surgeries, just kind of seeing how the dynamic between everyone that it takes to care for a patient, and how everyone approaches a patient differently,
Yeah, but also where all those roles are and how all those roles can be really beneficial. I think, and that's what's really cool at our hospital, of being able to say, hey, you can see, spend time on the acute care, then you can go to the inpatient rehab, then you can go to outpatient and home health, and kind of really see that continuum of care, not just for OT, but with PT and speech as well, and kind of see how all these rehab professions really work together, and the therapists and the therapy assistants, and kind of what those dynamics look like.
Yeah. Yeah, I love that. Experiential learning can be so beneficial, and I think it's really encouraging for professors or students to hear how important it is to get those experiences specifically related to OTA and OT collaboration while you're in school. I think that can be a huge benefit to curriculum and preparing for professional practice?
Right now, I have a student, I have an OTA student, and then Melissa, our OT, she has an OT student. And I like how those two students how they communicate with each other, and they even bounce ideas off each other. And we're all there together, chart reviewing, looking at things, and the communication that goes on between the four of us. Because, the OT student may have new ideas, and she's helping guide the OTA student. So, I feel like there's just a lot of different players, in the equation, that can provide so much just for those students to learn from, and they can learn from each other.
I think that's always a cool opportunity when that just happens to work out, where we have like an OTR and like a OTA student kind of at the same time in the same setting. Doesn't always pan out that way, but really makes for, I think, just a richer kind of learning experience for them to get to kind of live and work that relationship firsthand.
Absolutely. Absolutely. I'm sure there's a fieldwork coordinator listening to this now saying, I'm going to try and do that more frequently for our students. I just have two more questions for you both. What additional resources or certifications related to OTA collaboration would you recommend to our listeners?
I think this is a good one. And this really had me kind of scratching my head. And I was like, what do I go to for further information? And I think for me, it's really looking at my State Practice Act and how that defines the supervision between OT and OTA, and really what some of those specific definitions are, because it can really vary state by state. While we have a general consensus, some of the specifics can vary. And so I always kind of hold that up and kind of have that saved on my desktop to anytime I have, a student to say, hey, here's something to kind of be familiar with, or to know that is out there, and to pull up that. AOTA has a lot of really nice resources as well that kind of go into those details. And I like too that they have different resources that kind of present the information in a few different ways. You have the ethical document, but then you also have these kind of in the OT Practice magazine, a couple articles that really just speak to that relationship, and more from a kind of a clinical practice, in the weeds experience.
I love that. Those are wonderful resources, especially looking into the State Practice Act. I think that's an awesome recommendation that maybe listeners aren't even aware that your state has a practice act that defines these things. And that's important to at least read and reach out to others to help with understanding and applying that. This has been such a wonderful interview. It's great hearing, these everyday examples that you've been sharing. We end each episode of the show with the Golden Nugget segment. And I want to ask you both if you could share one piece of advice or one recommendation with our listeners. What would you say?
I'll go first. You have to be open. You have to be open to other people's opinions. You have to come from the standpoint, like I said earlier, that you're a lifelong learner. And just because I went to school, I didn't learn everything. A majority of what I have learned to this day is from actually practicing and working together with OTs and learning from them, and working with other OTAs and learning from them. And you just have to be open, and you have to know every day I'm going to go learn something new. And I love it. I love that every day I learn something new. And there's a new diagnosis that I haven't worked with, or, every patient is different. Not one of them are exactly alike.
That's beautiful. That's a beautiful golden nugget, Jen. And Amanda, how about you? What can you share with our listeners?
I think for me, my golden nugget right now would be kind of being okay with vulnerability and being okay with not knowing all the answers. Because I think in my first few years of practice, I felt like I almost couldn't admit that if I didn't know something. And I feel like that led to a lot of difficulty kind of in the long run, and maybe not the best for my patients every time. And so I think there's a lot of beauty in kind of the vulnerability of being hey, hey, I haven't seen this before, but I know you have, and really kind of being able to kind of lean on those around you or reach out to other OTs that you know or people you went to school with that might be able to like assist you with that one particular case. So kind of being vulnerable and willing to reach out and ask for help if you need it.
I love that. Thank you for sharing your wisdom, your recommendations with us. It's been delightful to speak with you and to get to know you both a little bit and learn from you. So I really appreciate you sharing this knowledge with our listeners. And thank you again for taking the time.
Yeah, thank you for having us.
Thanks for listening to the AOTA podcast. Tune in again next time.